All right, if you're a nursing student, you know there are some conditions that just pop up everywhere on exams, in your clinicals, you name it. Hyperthyroidism is definitely one of them. It's that state where the body's engine is just stuck in overdrive. So, in this explainer, we're going to break down exactly what you need to know to nail your tests and feel confident at the bedside. We're going to walk through this just like you would with a real patient. First up, we'll get into what's actually going wrong inside the body. Then, we'll look at all the clues the patient is giving us, how we confirm our suspicions with hard data, and of course, the treatments we use to fix it. We'll wrap things up with the nursing care that makes all the difference and the one red flag emergency you absolutely have to be ready for. Okay, let's get into the nitty-gritty. Before we can really understand why the thyroid goes haywire, we need to have a solid grasp on what its normal, everyday job is supposed to be.
So here's the most important thing to get. Hyperthyroidism isn't the body doing new things, it's the body's normal functions just turned up to 11. Imagine the body's metabolism is a car with the gas pedal floored, just burning through fuel at a crazy, unsustainable rate. Every single system gets pulled into this.
Normally, this is a beautifully balanced system. Think of the pituitary gland as the manager and the thyroid as the worker. The manager sends out TSH, which is basically a work order telling the thyroid to make hormones. Once the job is done and hormone levels are good, the manager stops sending orders. Simple, right? But in Graves' disease, this whole system gets hijacked. The thyroid just keeps churning out hormones, completely ignoring the manager who is screaming for it to stop. So, with the body's metabolism just raging, what does this actually look like when a patient walks through the door? This is where your assessment skills are absolutely crucial for catching it early.
Your classic patient is very often a woman between 30 and 50. So when she tells you she's always hot, she's losing weight even though she's eating everything in sight, and her heart feels like it's going to beat out of her chest, well, your hyperthyroidism alarm bells should be ringing off the hook. These are those classic signs you have to cluster together.
Now this is where you really start to play detective. While a lot of these symptoms can show up with any kind of hyperthyroidism, signs like exophthalmos, that really distinct bulging of the eyes, and pretibial myxedema are specific only to Graves' disease. Seeing those points you directly to that autoimmune cause.
Okay, so your assessment has you feeling pretty certain, but you need to prove it, right? So let's move on and see how we confirm all this with some cold, hard data from labs and diagnostic tests. This slide right here is your lab value cheat sheet. You need to burn this picture into your brain. First, TSH is low. That's the pituitary yelling, stop. Then the thyroid hormones themselves, T3 and T4, are super high, which confirms that hypermetabolic state. And the smoking gun for Graves' disease, elevated thyroid-stimulating immunoglobulins, or TSI. That's the rogue antibody causing all the trouble. And beyond the blood work, these procedures really fill in the bigger picture. An ECG is absolutely critical because of the massive strain on the heart. AFib is a common and really dangerous complication. And that thyroid scan, it shows us just how out of control those thyroid cells are by measuring how much of a radioactive isotope they suck up. A lot of uptake means a lot of activity. All right, the diagnosis is in. Our entire goal now shifts to calming this metabolic storm. We have to get those hormone levels down and manage the pretty awful symptoms they're causing. So here are the main ways we're going to do that. This slide is perfect for your notes. It perfectly lays out our two main medication strategies. You've got thionamides, like methimazole, which actually get to the root of the problem and stop the thyroid from making new hormones. Then you have beta blockers, like propranolol, which are basically for damage control. They don't fix the thyroid, but they protect the heart from those dangerously high heart rates. For your patient's safety and for your exams, these monitoring points are totally non-negotiable. With thionamides, you're watching to make sure you don't overshoot and cause hypothyroidism, but you're also watching for really serious side effects like a drop in white blood cells or liver damage. And for beta blockers, it is all about hemodynamics. You do not give that dose if the heart rate is already sitting below 60. When meds aren't the long-term answer, we move on to more definitive, more permanent solutions. We can either use radioactive iodine to quietly destroy the overactive thyroid cells from the inside out, or we can go in surgically and just take out the gland itself. So the key takeaway here is that your post-op care has to be tailored. After radioactive iodine, you're basically a radiation safety officer. But after a thyroidectomy, you are an airway and bleeding expert. Just remember your ABCs: airway, bleeding, and calcium. We always check the back of the neck for bleeding, and we watch like a hawk for signs of low calcium because the parathyroid glands can get accidentally damaged. Okay, so beyond all the high-tech meds and procedures, it's your fundamental, hands-on nursing care that really gets these patients through the day safely and with some level of comfort. Every single one of these interventions is a direct counterattack on a symptom. Their metabolism is through the roof, so we give them high-calorie food. They're burning up, so we cool the room down. They're anxious and hyper, so we create a calm space. They can't close their eyes properly because of the exophthalmos, so we protect their corneas with lubricants. This is where nursing truly makes a huge impact. I want you to just stare at this number for a second. Burn it into your memory. This single degree Fahrenheit is one of the most important, most critical vital signs you will ever monitor in a patient with hyperthyroidism. Why? Because a 1-degree temperature jump, something that might seem totally minor in another patient, could be the very first sign that your patient is tipping over the edge into a full-blown, life-threatening crisis. Calling the provider right away isn't just good practice, it is potentially life-saving.
So, what happens if that temperature spike goes unnoticed? Well, that brings us to the most dangerous complication you will ever face with this condition: thyroid storm.
Now let's be crystal clear. This is not just a bad case of hyperthyroidism. This is a sudden, massive, uncontrolled surge of thyroid hormones into the bloodstream. It is an absolute medical emergency with a frighteningly high mortality rate, and your rapid response is everything. You're going to look for the extreme versions of the symptoms we already talked about: a really high fever, severe hypertension, and acute delirium. Your immediate actions are all about support, but they're vital. You're focused on keeping that airway open, getting oxygen on board, aggressively cooling the patient, and pushing IV fluids to keep their blood pressure from collapsing. And here it is, a critical piece of information for your exams and for your entire career. You might instinctively reach for aspirin to bring down a high fever, right? But in this one specific case, it is absolutely forbidden. Aspirin actually makes the storm worse by knocking thyroid hormone off of proteins, which increases the amount of active hormone in the blood. So never, ever give it. We'll end with this thought to bring it all right back to the bedside. Knowing the answer here, which is that numbness and tingling around the mouth, in the fingers and toes, is what lets you step in early. It's what keeps your post-op patient from progressing to muscle tetany and seizures. It's that kind of sharp, vigilant nursing that makes all the difference in the world.